Hey guys, my name is Jake Sween. I'm a program coordinator here at AC, and today I was going to discuss first pass endotracheal intubation success and why it's so important, and things paramedics can do throughout their time providing care that allow them to continuously learn as they approach every airway and do it in a systematic way to ensure first pass success. Every airway is different, and every airway is a learning opportunity. You learn just as much from failures as you do successes, but due to the acuity, routinely we attempt to make every attempt a first pass success. A solid knowledge of airway anatomy plays a huge role in your ability to successfully pass endotracheal tubes with the first attempt every time. Every time you approach a patient's airway, from the time that you consider the need to intubate them right up until you pass the blade from the laryngoscope into their mouth, it's a continued assessment, and you're preparing to ensure that you can get the tube passed with the first attempt. One of the things that I would always recommend outside of routine equipment checks and knowing your equipment is where everything is and having an initial plan for first pass success every time. I would never approach an endotracheal intubation without having suction on hand and running. You may not always need it, but every time that you choose to attempt to intubate a patient without it present is going to be a time you'll need it, and that's quantified as a failure every time you have to withdraw that blade and abandon the attempt. One of the places I like to stage it once it's on and running is right underneath of the patient's shoulder where my right hand can access it. You can always have people help you check equipment, but from a perspective of making sure you know that everything's functional, make sure your cuffs and balloons are inflated, make sure you have a syringe on hand. I usually don't connect it in advance simply because it could accidentally allow air in, and you want to make sure the balloon is as small as possible. My preferred method for first pass success is I use a bougie in concert with either direct or video laryngoscopy every time. Most adults, I prefer a curved blade, will be able to take a Macintosh number 3 blade. I like this simply because I feel like I have more control once I place the blade in over the tongue due to its width. However, continuing to train with both straight and curved blades is critical. Anytime you begin to pass a tube or place the blade into a patient's mouth, once you've performed your size up assessment and figured out that you need to intubate them, is you need to visualize and think about the airway as you pass by and identify landmarks just like a road map to find that glottic opening and to find the trachea to place your tube. Every time I open a patient's mouth, I'm thinking about, I'm moving their lips out of the way conscientiously. I'm making sure when I pry open their airway that I don't squeeze their lips against their teeth and potentially cut them. As I pass the blade in, I'm looking down into their airway to see if there's any detritus or liquid in the airway that I need to suction out before I place the tube. If that is the case, you can always suction out what you need, and then as you pass the blade, you can come in and follow on with suction to use a suction-assisted laryngeal decontamination technique, or SALAD. So I'm looking at the lips, the teeth, the tongue. I'm sliding the tongue or the blade down the back of the tongue. I'm ensuring that I scoop the tongue out of the way. I'm looking, I can see the back of the airway, and just now I can begin to see the epiglottis, so I know I'm in the right place. I'm following that on my way down. Because this is a curved Macintosh blade, I'm going to insert it into that vallecula space that will allow me to lift the hyoepiglottic ligament. Once I lift it and I obtain a decent view, I can identify my cuneiform and arytenoid cartilages, I can identify the vestibular folds, and I can find my glottic opening. Once that's determined and I'm prepared to make my attempt to pass the tube, I insert my bougie in laterally right on the corner of the side of the mouth. I'm going to insert it and I'm going to feed it in until it comes to a firm stop. I'll maintain the blade in the patient's mouth to displace any tissue. Obviously, this is ideal with assistance, but in this case, since I don't have any, I have to pass the tube myself. I tend to not preload the tube because it makes it harder to use the bougie as designed, but leaving the tube in place, the blade in place, allows me to ensure that I am visualizing the tube as it passes the cords. And from here, as I gently insert, I wait until I get my indicator line just past the vestibular folds and the cords. I'm here. I can identify that I'm in place. At this point, I'll remove the blade, maintain positive control of the tube, declare where it's at. This is going to be 22 centimeters at the teeth with a 7.5 ET tube. I'll remove my bougie. I will inflate my cuff, making sure that once you've inflated air, what you can do is allow back pressure to help release from the syringe so you don't cause any hypoxia or damage to the tissues underneath, introducing necrosis. From there, because I pre-staged my commercial tube holder, what that allows me to do is insert the bite block, make sure it's in place, maintain control of my tube and ensure it hasn't shifted from my original place. secure it, and because I pre-stage it, it's safe at this point for me to release the tube, but until it's fully secured, I'll go through, secure my tube holder, and at this point, I'll verify placement by introducing waveform capnography, which is the gold standard. I will ensure we have equal chest rise and fall when I ventilate the patient. I will ensure I have waveform capnography, and then I will auscultate breath sounds bilaterally and ensure there are absent sounds over the epigastrum. I like to pre-stage my BVMs to ensure I have PEEP available if I do need it, so I don't go looking for one of these if I need it. I can always leave it all the way backed off, but it's good to have when available. And remember, every airway attempt that you ever make and every airway you ever manage in EMS, even if it's just bag valve ventilations, is an opportunity for you to perform a thorough airway assessment. Whether or not you manage an airway, every time that you're able to observe, especially if a video laryngoscope is available, for you to see airway landmarks and learn from both other people's successes and failures and your own, allows you to grow as a provider and provide the best care possible.